in- influenza, grip, grip flu, and acute viral respiratory infection with influenza, a virus causing fever, coryza, cough, headache, malaise, and inflamed respiratory mucous membranes. Etiology: influenza or flu is commonly and incorrectly used by laymen and some health professionals to refer to respiratory infections that are not caused by influenza virus. Influenza virus, which are orthomitrovirus, are classified as types A, B, or C by complement fixing antibodies to the nucleoprotein and matrix proteins. Influenza C virus infections does not cause classic influenza illness and is not discussed here. Influenza virus have two principal surface glycoproteins, hemagglutinin HA and neuraminidase NA. They permit the virus to attach to and infect susceptible hosts and are targets of significant host immunologic responses. HA allows that virus to bind to cellular salicylic acid and to fuse with the host membrane. Na functions as an enzyme to remove salicylic acid, preventing self-aggregation and promoting dispersion during bonding of new virions from the infected cell. Currently, only a single serologic type of influenza V virus is recognized, although strain variability is demonstrable by antigenicity of HA and NA. However, influenza A virus have been categorized into subtypes based on direct antigenic divergences of HAs and NAs. Mutations of HA and NA within a type of influenza virus are known as antigenic drift, a continuous process for both influenza A and B virus. Antigenic drift can be substantial and has led to an extensive epidemics with severe disease. Exchange of entire gene segments between virus of human and animal, usually having origin, produce new reassorted virus in a process known as antigenic shift. Antigenic shift has occurred only with influenza A virus, resulting in pandemics. An avian strain of influenza A, H5N1, emerged as cause of human influenza in 18 documented cases in Hong Kong in 1997, but pandemic spread did not occur. Epidemiology: influenza produces widespread sporadic respiratory illness during fall and winter, every year in temperate climates. Epidemics in the USA, often with surging absenteeism, morbidity, and mortality, occur about every 2 to 3 years, most often caused by influenza A, H3N2 viruses. Influenza B virus typically cause mild respiratory disease but can cause significant morbidity, and mortality during an epidemic typically in 3 to 5 year cycles. Also, most epidemics are caused by a single stereotype in given seasons. Different influenza viruses have appeared sequentially in one location or have appeared simultaneously, with one virus predominating in one location and another virus predominating elsewhere. The prevalence of infection is highest in school-age children. Seasonal epidemics often occur in two waves. The first in school children and their household contacts, generally young persons, and the second mostly in shut-ins and persons in semi-closed institutions, generally older persons. Spread of influenza virus is by airborne droplets, person-to-person contact, or contact with contaminated items. Air travel which permits prolonged contact in relative confinement with infected persons may seed new virus strains and transport epidemic strains to new areas. Persons at high risk of developing severe disease are those with chronic pulmonary diseases and those with valvular heart disease, which or without heart failure, or other heart disease with pulmonary edema. Pregnant women in the third trimester, the elderly, the very young, and the bedridden are also at the increased risk of severe disease with fatality. Symptoms and signs. During the 48-hour incubation period after infection, virus replicates in the respiratory tract and transient asymptomatic viremia may occur. In mild case, in resistance or particularly immune host, the symptoms are like those of a common cold. Chills and fever up to 39 to 39.5 Celsius, 102 to 103 Fahrenheit, being suddenly prostractions and generalized aches and pains, most pronounced in the back and legs, appear early. Headache is prominent, often with photophobia and retrobulbar aching. Respiratory tract symptoms may be mild at first, with a scratchy, sore throat, substantial burning, non-productive cough, and sometimes cralgia. Later, the lower respiratory illness becomes dominant. Cough can be persistent and productive. In severe cases, symptoms may be bloody. Skin is warm and flushed. Soft palate, posterior hard plaque, tonsillar pillars, and posterior pharyngeal wall may be redundant, but no exudate appears. Eye water easily, and the conjunctiva may be mildly inflamed. Nausea and vomiting may occur on children. After 2 or 3 days, acute symptoms rapidly subside and fever ends. Although fever may last up to 5 days without complications, abnormal lung clearance and altered bronchial airflow can be demonstrated. Weakness, sweating, and fatigue may persist for several days or occasionally for weeks. Hemorrhagic bronchitis and pneumonia may occur and be rapidly progressive. Fulminant fatal pneumonia may be viral, bacteria, or mixed viral bacteria. When the occur symptoms of dyspnea and blood symptom associated with pulmonary congestion and edema may end with death in as little as 48 hours after onset. Such serious diseases most likely occurs during a pandemic caused by a new influenza A stereotype and in persons with cardiac or pulmonary risk factors. Secondary by bacterial infections of bronchi and lungs may commonly pneumococcal or staphylococcal is suggested by persistence or recurrence of fever, cough, and other respiratory symptoms in the second week. When pneumonia develops, cough worsens, and purulent or blood symptoms is produced, crepitant or subcrepitant rails can be detected or over the involved pulmonary segments. See as also chapter 73. Encephalitis, myocarditis, and microbial are infrequent complications of influenza and if persist usually occur during convalescence. Virus is rarely recovered from organs outside the respiratory tract and specific roles in the pathogenesis of the extrapulmonary diseases cannot be positively established. However, an increase in incidence of such diseases regularly follows influenza A pandemics. Rare syndrome C under mesothelioma infection in chapter 265, characterized by encephalopathy, fatty liver, hyperglycemia, and lipidemia has been prominently associated with epidemics of influenza B, particularly in children who have ingested aspirin. Diagnosis: in uncomplicated influenza, the leukocyte count is normal. Fever and severe constitutional symptoms differentiate influenza from the common cold. In the early stages of infections or in an uncomplicated cases, chest examinations is normal. During epidemics, early isolations and identifications of the type and antigenic character of influenza virus can be used to recommend continued vaccinations efforts and to recommend antiviral agents. Local or state health departments and the Centers for Disease Control and WHO collaborating influenza centers are available to assist in strain identifications. Although rare indeed, a specific diagnosis can be made definitively by isolating virus, demonstrating infected cells in circulations using immunologic or more molecular methods to detect viral constitutions. Students or demonstrating a rise in antibody specific or HA or NA in serologic tests. The virus is most easily recovered from respiratory secretions by replications in tissue cultures. The specimens can be collected and as stipple, but the nasopharyngeal washings or gargles obtained in buffered saline solution provide better yield. Yield is maximal during the early symptomatic phases, but testing circulations on more than 1 day improvement recovery. A small amount of protein such as albumin or gelatin added after collections stabilizes the viability of the virus. Diluted skim milk has been used as collections and transport medium. Serologic tests used to establish infections are complement fixations, CF, and hemigranulations inhibiting HI tests, but enzyme-linked immunosorbent assay techniques are increasingly being used. When needed, serum secrements are best collected at the onset of illness and 2 weeks later. The two segments are tested simultaneously to show a rise in the specific antibody titer. If one single serum specimen is available after development of diseases, a high antibody titer may indicate recent infections. The HI titer correlates best with serum neutralizations of virus and can be used as an index of protection agent against infections by specific strains. Leukocytosis with a shift toward juvenile granulosis in blood simmer is a valuable sign of complicating bacterial or mixed viral bacterial pneumonia. Purulent sputum specimens should be collected for smear gram strain and examinations for leukocytes and bacteria. When complications occur, stumps and blood cultures and other diagnosis tests should be performed to identify the specific bacterial species and its antimicrobial susceptibility. Differential diagnosis includes other viral causes for respiratory illness that resemble influenza, parainfluenza virus, respiratory syncytial virus, and rhinovirus and echovirus. In distinguishing influenza from other respiratory tract infections that epidemically seasons of the year and no occurrence of influenza in the commonly can be important. Prognosis. Although even healthy persons demonstrate defections in lung clearance and ventilation or for several weeks after acute illness, recovery is the road to uncomplicated influenza. Severe virus-related complications require hospitalizations and threaten life most frequently as extreme age children lower than 12 most and adults lower than higher than 65 years, and among persons with chronic cardiac or especially pulmonary conditions. Mortality related in pneumonia and influenza, one of the 10 leading causes of death in the USA, has routinely spread to 20,000 persons annually during epidemics in the past 20 years. Appropriate antibiotic therapy decreases the mortality rate for the secondary viral pneumonia. Prophylaxis exposure to influenza virus by infection or immunization results temporary in resistance to reinfection with the same virus type. Immunization vaccines that includes the prevalent strains of influenza virus reduce the incidence of infections among vaccines which when the HAN or NA of the immunizing and infection strain matches. Less immunity is provided when appreciable agent antigenic difference occurs in the emergent strains of virus, and vaccination provides no protections when major antigenic mutations occurs unless the vaccine incorporates the new strain. Vaccine is prepared for the alloantotic flux of the infection egg embryos as inactive whole virus or sovereign preparations and is standardized to provide a specific antigenic method of HA. However, other methods of preparations are being explored, including HA and NA purified from protein protected by recombinant DNA techniques. Live attenuated virus vaccines give interestingly have recently been shown to produce immunity with easy and acceptable administrations. The elected specific secretory antibodies are the virus entry and may provide additional protections through immunologic responses, e.g., cytotoxic T lymphocytes induced by intravirus proteins. Yearly vaccinations is reminded for patients with cardiac and pulmonary diseases for the age for patients with many other chronic disease and for persons who provide their care at home or in the hospital. Since pneumonia frequently causes secondary bacterial pneumonia, a prudent and recommended strategy is immune persons at high risk of complications for influenza with pneumococcal vaccines only. Pregnant women who fall to a high risk category or whose third trimester occurs during the winter months should also be candidates for vaccinations with influenza vaccines. Annual immunization is recommended to maintain the antibody titer and reflect changes in vaccine strains. Immunizations in IM injections is best accomplished in fall, so the antibody titers will be high during the peak months of the influenza prevalence, November through March in the USA. In immunologically pregnant persons, the maximal response to the vaccinations can be expected to develop by about 2 weeks. When the survival vaccines currently available, local or constitutional reactions are uncommon or minor in a short duration. Children before 13 years old should receive substitution vaccine because the side effects are fewer. Because children have had fewer opportunities for exposure to influenza virus. Both primary and booster dose 0.5 milliliter each of the children 3 to 10 years, 0.25 milliliter each of the children 6 to 35 more. One more apart are recommended unless vaccinations have been administered in prior years. For adults, 0.5 milliliter may be given as whole to submit vaccine. Antiviral drugs. Anti-mediated and remain-chained are antiviral drugs that are effective prophylactically against influenza A virus but not against influenza B. For both drugs, 100 milligrams per bid can be used to avoid adverse effects for accumulating drugs. The dose must be reduced for children 5 to 8 milligram to kilogram day per day, up to a maximum of 200 milligram per day for anti-mediate and 5 milligram per kilogram per day in a single dose to a maximum for 150 milligram per day for remained diet. For the elderly, no more than 100 milligram day, or if renal functions is impaired. The dose of ruminated should also be adjusted if hepatic deficiencies exist. When amantadine or rimantadine is given, persons who have not been vaccinated should receive vaccine, and antiviral drugs may be discontinued 2 to 3 weeks later if vaccine cannot be given, and amantadine or rimatidine must be continued for durations of epidemic, usually 6 or 8 weeks. Amantadine and ritamine cause pneumonitis, insomnia, or other CNS effects in about 10% of people. The adverse effects are those related and are more frequent with amantadine that rimanidine. They are more prominent in the elderly and those with CNS diseases or impaired renal functions. Drug resistance frequently occurs. Treatment for most parties is symptomatic. The patient should rest and maintain hydration. If symptoms of accurate and uncomplicated influenza are severe, anti-influenza common therapy, antivirals, and analgesics are helpful. Amantadine, amantadine and riamidine are beneficial for fever and respiratory symptoms if given early on uncomplicated influenza A or perhaps in viral pneumonia. Resistance to either drugs may make both ineffective. Resistant strains are not prevalent. Variant C as responsibility is virus infection under virus infection in chapter 265. Administered early in large oral dose in adults or by aerosol in children can strengthen the duration of fever and reduce viral shedding in influenza A or B infections. It has also been reported to reverse the course of primary influenza pneumonia. For adults, aspirin 600 milligrams or acetaminophen 650 milligrams per Q4 hours may be administered. For children, only acetaminophen and 10 to 15 milligrams per kilograms Q4 to 6 hours, not to be exceeded 5 doses per 24 hours, should be recommended. Since aspirin may increase the risk of Rayleigh syndrome, to relieve nasal obstructions. A nasal decongestant, see Table 162 to 3, may be used temporarily. Steam inhalations may relieve respiratory symptoms and prevent some of the discomfort of dry membranes and irritated secretions. Treatment of respiratory symptoms may be unnecessary to less severe cases. Complicating bacterial infections required appropriate antibiotics. Parainfluenza virus, the closely related virus causing many respiratory illness varying from the common cold to influenza like pneumonia, with febrile cough as the most common severe manifestation. The parainfluenza virus are paraexovirus types 1, 2, 3, and 4. The types are similar structurally and biologically, but they tended to cause diseases to different severity, even though they share common antigens as evidenced by cross-reactive antibody responses. Type 4 has antigenic cross-reactivity with mumps. Epidemiology and parainfluenza virus infection, especially type 3, occurs throughout the year. Crop or Laryngorteria oblongosus type 1 and 2 are epidemic in children in the fall and are of greater concern that they generally mild upper uh, respiratory illness during reinfections. The among almost universal immunity in adults cause of the reduced severity of illness in adults and may severe in impede the spread of parainfluenza virus. However, two and second and even third infections can occur with the same virus, particularly parainfluenza virus type 1 and 3. First infections with parainfluenza virus type 1 and 3 are common to early childhood. Localized outbreaks occur in nurseries, pediatric wards, schools, and other settings with children. Type 3 diseases is endemic, is highly contagious, occurs in all seasons, and affects a high proportion of all children in the first year of life. Epidemic disease caused by parainfluenza virus type 1 or 2 tend to occur annually, with each type predominating a pattern of alternating years. Illness from type 2 tends to be more sporadic. The sporadic type 1, 2, and 3 may circulate during a single fall season. Type 4 causes mild respiratory illness. Symptoms, signs, and complications. The most common illness product in children is acute febrile respiratory infections that is clinically indistinguishable from influenza or other respiratory virus infections occurring in the same age group. The infection period varies somewhat and depends in part of the infection virus, usually 24 to 48 hours for parainfluenza virus type 3, but 4 and 5 days for parainfluenza virus type 1. Onset is marked by fever and moderate chorosia. The degree of malaise is directly related to the intensity of the fever. In many cases, the temperature does not exceed 38 degrees Fahrenheit, 101 Fahrenheit, and others it may peak several times in 40 Fahrenheit, 104 Fahrenheit. Fever may subside promptly or continue for 2 to 3 days. In some, particularly those who develop lower respiratory tract involvement for fever lasting lower than 1 week may recur one or more times. Moderate sore throat and dry cough usually develop early in the disease. Hoarseness and cough are prominent in many cases. This crop accurate is the most severe and dangerous manifestations of parainfluenza virus infection in children and often requires hospitalization. See chapter 265. Bronchitis and walking viral pneumonia often develop during and after an injury acute episode in children and sometimes in adults infected with type 3. Pneumonia may be detected by excavations revealing moisture rails in one or more two lungs areas, but more certainly by chest x-ray. Bacterial complications are uncommon. However, as with other respiratory virus infections, accurate inactivations of asthma or thoracic bronchitis may occur. See codes under viral infections in chapter 265. Diagnosis. A specific diagnosis cannot be made clinically. When indicated, virus isolations and identifications can be performed through tester culture inoculation. Viral antigens can be detected in infected cells from the respiratory tract by immunologic and molecular methods, CFHI, and neutralization tests with sperm supplements for the accurate and convalescent stages can confirm parainfluenza infections, but certain cross-reactions can make identifications of the specific virus type difficult without the virus isolate. Prognosis, prophylaxis, and treatment. Expect of infantile cough and viral pneumonia illness due to the parainfluenza virus, although frequent, are usually mild, self-limited, and short-lived. The bronchitis and the pneumonia associated with type 3 infections seldom cause serious disability and are rarely fatal. No specific therapy exists. Rest and comfortable environment are the best remedies. If the fever is high to the symptoms prevent sleep, acetaminophen may give relief. If children require anti-reactics or antigenics, anti-aminofen is preferable to aspirin to avoid the risk of rare syndrome with influenza. If necessary, anti-tissues with e.g. dextromethorphan 1 to 1.5 milligram per kilogram per day pro in 6 divided dozens may be given to suppress cough. For treatment of crop culture under viral infections in chapter 265. Adenovirus, a group of many viruses, some of which causes acute fever disorders characterized by inflammations of respiratory and ocular mucous membranes and hyperplasia of mucous and regional lymphatic tissue. Adenovirus are DNA viruses with three major antigens, hexane, pentan, and fiber directly related to the capsid structures. These antigens can be used to identify a type of the virus. Sometimes adenovirus are accompanied by the similar DNA virus called the adeno-associated virus, which is defective and must be complemented by the adenovirus replicate. The importance of this virus is unknown. Epidemiology. About 4 to 5% of clinically recurrent respiratory illness in civilization populations are caused by adenovirus. Only a few of the more than 40 known stereotypes have been studied antiquely and determined the role in producing human disease. See Table 162 to 4. Different stereotypes have different epidemiology. Type 1, 2, and 5 causes sharp, limited outbreaks of respiratory or athletic illness during the first few months of the year of life, with type 2 being somewhat more common in certain episodes. This type 3 causes characteristic syndrome of acquired physiological genetic fiber APC in older children and adults observed, especially in summer camps and swimming pools. Acute respiratory disease (ARD) occurs in military recruit camps and caused by types 4, 7, 14, and 2T1. ARD epidemics also occur among civilian populations in some countries but are not identified frequently in the USA. Epidemic ketoacidosis virus is caused by the several stereotypes and occurs largely among persons in industrial plants and ice clinics. Some adenovirus types infect only in intestinal tract, often without causing symptoms. Also, interact methotic antigens and in tissues contained by can occur. Infection with adenovirus type 1, 2, and 5 results in large of virus in the tonsils and adonis. About 80% of executive tonsils yield such virus. In winter, infection with type 4 and 7 causes responsible illness in military recruits, with about 25% recruiting hospitalization for fever and lower respiratory tract diseases. In summer, APC occurs in a high proportion to type 3 infections. Adenovirus can commonly acquired by the contact with a structures for an infected person or by contact with contaminated object. Infections is airborne or waterborne, acquired by swimming. Table 162 for syndromes caused by adenovirus diseases. Respiratory acquired fever respiratory disease of children. Syndrome inbreeding type common 1, 2, 3, 4, 5, 6. Less common other types. Commonness. Probably the most frequent manifestation are adenovirus type 1, 2, and 5, and endemic type 3, occasionally epidemic, more prevalent during the cold months. Accurate respiratory diseases, ARD, 4, 7, 14, 21, epidemic in military recruits, sporadic in adult civilizations, type 4 and 7 infections rare in children. Viral pneumonia infants, 7.1.3. Rare occasion in hospital nurseries may be fatal, similar to good pasture inculcation by pneumonic ticks. Adults 4, 7, 3, 21, predominantly associated with ARD, cold aggregations not developed. Ocular for their conjunctive 3, 7, 2, 4, 6, 9, 10, 21. Spiritually active, cheerfully adults and children usually associated with respiratory and systemic effects. Epidemic cultural Article 6. 8 classic. 3, 7, 19 mild. Epidemic affects mainly adults, widespread in Japan, rare in USA. Here. Combined respiratory and ocular, accurate for the controlled fever. 1, 2, 5, 6, 14, 21. Epidemic in children, sporadic in adults. Summer epidemic frequently also in swimming pools and lakes. Symptoms and signs. Accurate fiber responsibility disease is the usual manifestations of symptomatic unknown viral infections in children. The incubation period is up to 10 days. In typical one break confined to household or nursery, some affected children have only fever without locating signs. Others have fever and paralysis. Others have fever with paralysis, tragedies and bronchitis, and moderately persistent non-productive cough, and rarely pneumonia. The cough with adenoviral pneumonia has been confused with the process in children. Pulmonary lymphocyte hypertrophy sometimes persists, leading to tube obstructions and possibly osis media. Regional lymph nodes are frequently enlarged and sometimes tender, but they never spurcate. Laboratory findings usually are within normal limits, although lymph node cysts sometimes occurs. The syndrome designated accurate respiratory disease (ARD) has been observed in military recruits during periods of troop mobilization. ARD is marked by malaria, fever, chills, and headache. Respiratory manifestations include pharyngitis, harrosis, and dry cough. The diseases may responsible Staphylococcus meningitis infections, multiple causes. Several antipathy is present, but the nodes are not as tender as a streptococcus parasites. I find interesting macular rash may appear on the body, and environmental invasion may be shown. But the virus does not produce symptoms like those of the epidemic hemorrhagic crisis that occurs at the primary disease with adenovirus type 11. Physical signs as minimal expected about 10% of pathogens with developed rates and X-ray evidence of pneumonia. Fever usually subsides with 2 to 4 days. Convalescent while uneventful may require another 10 to 14 days. In immunocompromised persons, coronavirus and virus shedding can be occur. Virtual pneumonia in infants is rare but specific. Clinical pathological entry. Small outbreaks have occurred in France, South Africa, and the USA, China, and Japan with fatalities result from expected pneumonia. Accurate fatality conjunctival fever (APC) produced the clinical trait of fever, pharyngitis, and conjunctivitis. Infections is sometimes acquired by impossibly contaminated water. The incubation period is 5 to 10 days. In typical outbreak, more than 50% of the patients have all three components of the clinical trait, while the remainder experience one or two of the symptoms. The conjunction virus is vitreous is entirely undetailed and sometimes painful. Lower respiratory tract involvement with cough may occur in addition to paralysis. The illness usually subsides within a week, but follicular conjunctivitis may persist for several more days. Conjunctivitis with continual symptoms is a common manifestation of the infections with several different adenovirus serotypes. It occurs most often in young adults, chiefly parts of children with APC, and is self-limited and benign. Onset is sudden and unusually unresolved. Symptoms and signs include a foreign body sensations in the eye, like laryngitis and focal entry of peripheral verbal conjunctiva. The disease charge is multiplied by the problem. In about half of the patients of the other eyes is subsequently involved, usually less severity, persist follicular enlargement of some carotid liver tissues under the peripheral conjunctiva. Even early pneumonia may be seen at 2 to 4 days about onset. preacular and posterior cerebral lymph node antibody and inevitably more prominent of the same side as the more involved eye is usual. A mind sore throat occasionally develops often on the same side of the affected eye. The really the cause is mine. Also, the functional causes, the human rights and professional media occur occasionally. Epidemic criterion SKC is specific, sometimes severe. Epidemic diseases caused by adenovirus observed for many years in Japan. It became epidemic in the USA during the World War II, chiefly among shipyard workers of body coast. It had occurred only sort of in countryside, but widespread epidemics have occurred in Europe and Asia. Onset sudden on the eyes of redness and concept followed by preorbital sweating, preparcular and special corneal occupation, opacities. Unlike herpes Sclerosis is not result to control alcohol, however, local pain like that from foreign body irritation is usual. The ocular eye may become involved within a week. Symptoms and signs are most abstract. EKC usually resolved within 3 or 4 weeks, although clinical olfaction may persist much longer and visions may be permanently impaired. And autophagy has disclosed microscopically unique extensive inclusion body pneumonia. The intranuclear enclosures appear similar to those seen to tissue cultures. By segment of spiritual lesson provided by the adenovirus is conjunction and peritoneal mucous show capillary occasional submucous hemorrhages and vaginal infections, but not intraocular inclusions. The conjunctive caused by the common respiratory adenovirus type is usually began, but sometimes keratoconjunctive with as caused by type 8 with corneal opacities and impaired vision occurs. Diagnosis, clinical identifications of adenovirus interactions is only presumptive. Expect the epidemics of APC, EKC, and ARD in those conditions. Uh, the clinical epidemiologic characteristics of both like are unmistakable. During the crisis stage of abnormal illness, the virus can be isolated for 7 to 10 days from responding and occurs and frequently from faces to anger. Although this is rarely done, except for the immunologic interaction, fourfold rise in the serum antibody titers in indicates recent adenoviral infections. Prognosis and prophylaxis. Adenoviral infections are generally begin and are relatively short-lived, except of the rare cases of fulminating primary pneumonia, predominantly in infants and military recruits. Even severe pneumonia is not fatal. Vaccines contain live virus type of 4 and 7 given occurring evidence-coded culture has markedly reduced ARD in military populations. However, they are neither recommended nor available for citizens' use. Spread of virus without vaccines is improbable, but possible, but inconsequential. Vaccines for few other serotypes has been developed, but are not commonly available. Washing is critical since among civilians, adenovirus causing outbreaks of conjunctivitis are spread by contact with contaminated objects, easy towels and instruments, by secretions, by finger transmissions, proper sterilization techniques, changing gloves and washing hands before and after examining infected patients, and avoiding multiple patient exposures to ophthalmologic instruments are recommended to prevent transfer of the virus by healthy persons. Treatment. Treatment is symptomatic and supportive. Bed rest may be required during the acute febrile period. Aspirin is not recommended unless headache and malaise are distressing. For children, acetaminophen may be preferred because of the concerns of Raynaud syndrome. Analgesics such as Gondan are rarely necessary. Severe pneumonia in infants and EKC require close supervision to prevent death in formal and permanently impaired visions in the later. Typical concentrated relief symptoms and shorten the course of EKC and adenoidal conjunctivitis. Such therapy is dangerous in ultra-rare corneal conditions, however, and should always be supervised by an ophthalmologist.